I'm just going to do a quick intro of the folks, and they're going to introduce themselves. The topic is role of clinical leadership to achieving successful digital health implementation. So we've got quite a great group of folks here on the podium today. So I'll start off with Sarah. So Sarah, why don't you start just introducing yourself, and we'll just go. Up there? No, we're firside.
Okay, great. So I hope this is working. Great, good.
Sarah's quite unwell, so
I'm not dying. I just
quite unwell. So we have to bear with Sarah.
Sorry, I apologize. I do have a cold. For those of you that don't know me, I am Sarah Muttitt. I'm currently the Chief Information Officer at the Hospital for Sick Children, where I trained and practiced a quarter century ago, as I've been reminded. And I've now been reintroduced to the viral load of working in a pediatric hospital. So unfortunately, I'm carrying a bit of a cold today. I am a bit humbled, actually. I'm humbled being on the panel with these two people for sure, and with Asim. I'm also humbled when I look around the room, because quite honestly, there's a lot of superb clinical leaders in this room, many of whom have been role models for me, and many of whom have been on the journey with me. So it is very nice to be here, and it's a topic that I think is really important, because I think a lot of the success that we've been discussing today and where we want to be in 2020 and beyond really requires outstanding clinical leadership. And my background, as I said, I'm a pediatrician, I'm a newborn intensivist, and I ended up in technology out of pure need. I'm not a technologist by any extent at all, and I think anybody who's worked with me knows that for sure. I have to surround myself with excellence when it comes to technology and technology expertise. But I was working in a private clinic at the time, in pediatric rehab, working with the kids that were graduating out of the newborn intensive care with multiple disabilities and challenges. And we were trying to find some new ways to actually enhance their functionality and independence. And we were trying a lot of new therapies, a lot of new modalities, electric stimulation, a lot of different things. And these patients were coming to see us from around the world. I had practitioners around the world, but I also had hundreds of patients in a clinical trial. And what I would receive every month or so from their parents was what was inevitably an incompatible VHS tape. And there's probably a few people in this room that still remember what a VHS tape is, but I got dozens and dozens of these every month that we didn't have machines that would play, or they arrived broken, and I was supposed to be monitoring their progress in terms of gait and posture and strength and all sorts of things, and I couldn't really do it. And so I ended up in telehealth, and there's a lot of people in this room, again, Kathy alluded to it earlier, that have been on the telehealth journey with me from the late 90s, early 2000s. But I gradually, after being in telehealth for a number of years, I got sucked into the electronic health record vortex, and have been there ever since, and have had the great fortune to work at Infoway and to get that national perspective about what we could do. Followed that in Singapore, where we implemented a national electronic health record, and I served as the CIO for the Ministry of Health. And most recently, I've been in Alberta as the Chief Medical Information Officer for the province, and now back at SickKids. As I tell Asim, I think people usually get small jobs and they get bigger and bigger and bigger. I've been kind of reverse engineering it, trying to bring it down from national, regional, provincial to a hospital. But we're on a journey right now of implementing a health information system and looking at the HIS renewal and so on, and doing that in partnership with another hospital here in Ontario, the Children's Hospital of Eastern Ontario, and beginning to build what we call a Kids Health Alliance. So what was a hospital is now becoming a network again. So I think my life went like this, and now it's going back out again, and all of that adds, tremendous opportunity, tremendous challenge, but the clinicians I need to work with to make this happen need to be good clinical leaders, and I need to be a bit of both. I need to have the technical and infrastructure leadership that's needed, but also to stand up and be the clinical leader that these sorts of collaborations and long-term relationships require. So I think I'll leave it there. So thanks.
That's excellent. So I'm going to go through the panel here from an introduction standpoint. Fiona has joined us recently, and she's, I guess yesterday you were up in the CN Tower, I think you said? Yeah. Had a clear day. You picked a clear day.
Fantastic. Fabulous weather.
I'll let Fiona take over from here. But she's...
Thank you very much. I'm delighted to be here, and it's absolutely fascinating looking at your journey and comparing it with the English journey. So I'm Fiona McDonald, and I'm the clinical lead currently for the electronic prescription service in England. So I've had some great conversations with Infoway yesterday about their e-prescribe it. So I do that 4 days a week. And actually, it's expanded from just what we call EPS. So in effect, it's generating an electronic prescription from your GP, transmitting it to a pharmacy of the patient's choice. That program's now expanded, and I don't know whether you keep up with what's going on in England, but we're currently working towards a paperless 2020, like the rest of the world. It feels like. But paperless 2020, so our program's expanded hugely into a digitising medicines domain. So that consists of about 14 different work streams and programs. So I'm the clinical lead across that domain. I also do, and I've been fascinated listening to some of the conversations, particularly yesterday afternoon at the Digital Forum. So I do a 1 day a week for NHS England. So my other company is NHS Digital, but 1 day a week for NHS England, working on the Patient Online programme. So that's very similar to what you're trying to do here. Patients ordering prescriptions online, booking appointments online, and accessing their GP medical record online. So that's my background. How did I get here? I'm not quite sure how I got here. I think like anybody working in clinical informatics at the moment, it's quite a new, it feels like there's a birth of a profession coming along. And I think I just fell into it. Always been a very early adopter of technology. So in the late 90s, we had a street party because we were the only ones in our street with an internet connection, and the Monica Lewinsky transcription was coming through. So we had a full house that day, but it came through really, really slowly, if anybody remembers those dial-up lines. So I had a little bit of time out of healthcare when my children were very young and struggling to coordinate 3 children. And I developed a holiday business just randomly, completely out of healthcare. And that was very much at a time when things were going online, and the holiday industry was looking at how they could streamline and make efficiencies. And I'm not quite sure. Anyway, so that's how I ended up back in healthcare and back in healthcare IT. I also have type 1 diabetes, and I have CGM. I've had it for a very, very long time, and as I said to Lynn and various people at Info yesterday, it's plus 40 years, but I won't tell you exactly how long because you'll know exactly how old I am. So I have a pump therapy, I have CGM. I've always been very interested in technology and how healthcare can actually be supported by technology and the developments out there. So I don't know whether I was just a very nosy patient, but even as a young person, 15, 16, I remember taking my paper medical records when they said, oh, just take your records and go somewhere else, and I'd go and sit in the toilet and read them. So, but I think there's people do want to engage in their own healthcare. So it's that's my journey. That's how I ended up here. So hope that's
great. Thank you very much.
enough. Asim.
Our next panelist is Andy, and we're delighted to have Andy again, another pediatrician, but with a varied and intricate background, I guess I would say.
Intricate. How many people here are Gilbert and Sullivan fans? Raise your hands. Anybody remember the story of Sir Joseph Porter, KCB, and the HMS Pinafore, and how he got to be the ruler of the Queen's Navy? He polished up the handle so carefully, and it's a series of accidental steps. It reminds me of that. My own life reminds me of that. I am, as Asim said, I'm a pediatrician. I'm a pediatric infectious disease clinician. And I, like Sarah, have absolutely zero training in engineering and informatics. But I was, early on in my career, an epidemic intelligence service officer, which is a CDC job, Centers for Disease Control job in the United States. I got very interested in what is today faddishly called population health and public health. I came to my organization, my clinical organization, which was Kaiser Permanente in the very beginning of the 1980s, with that background. So I was a trained infectious disease doctor. I spoke other languages, had lived and worked in Latin America, training as an epidemiologist. And very soon after that, the clinicians at the Permanente Medical Group in Colorado, where I was, said, you know what, we think you should design and build our quality management program. And I did that, and I discovered very quickly that I didn't have any automated data to use to measure quality or the use of resources or service. Nothing of that nature was automated. In the United States then, people outside of places like Kaiser Permanente had billing and claims systems, and they used the claims diagnoses to try to figure out what was going on when doctors and patients saw each other. But Kaiser didn't have a claim system because we didn't have any bills. It was all prepaid. So I had to do something else, and it was fortunate that I was completely ignorant. And I decided that we needed an electronic medical record, so I bought a PC, and I bought a book, and I taught myself how to write code, very badly as it turned out. I spent about a year trying to create an electronic medical record, and that was a really bad idea. But the germ of the idea was real, so I went to my organization and essentially did what we would today call a business case for an electronic medical record. That was in 1987 at Kaiser Permanente in Colorado. Embarked on a journey with IBM as a joint development partner and investment money from my operating region, and we successfully built what was then a proprietary electronic health record for all of Kaiser's physicians and clinicians and members in Colorado, which at the time was the size of a sort of health district here in Canada, so about 250,000 people and about 500 doctors of all specialties and so on. So I was a happy guy because I had what I wanted. It was generating data. By the way, we standardized on SNOMED CT even then because that was the idea. It was not about automating and making a big fancy typewriter. It was about generating information to improve care. And so we did that. My punishment for that was to be several years later asked to lead the electronic health record project nationally for all of Kaiser Permanente. So like many of your provinces, what we had done was regional in nature. Where I was in Colorado, we had an electronic health record. They had another electronic health record in the Ohio region. They had another one in Hawaii that was germinating, and another one in the mid-Atlantic states, and yet something else going on in Northern California and in the Pacific Northwest, all different things, but nothing unified, no platform of standard information about all of our patients. So I was given that task. And many of you know the result. It took us about 7 years, but we succeeded. And I retired because I could and because I wanted to do something else. I wanted to be Johnny Appleseed. So I actually don't know how I got there. I think that it helps to be a pediatrician. I've often mentioned this whimsically to Sarah because you know when other doctors need to take time out. It helps to have a thick skin. I think that understanding technology is necessary, but it's not necessary to be a technologist. It's also necessary to understand the world of the chief financial officer, because if you can't speak their language, then you can't make the case, and they have limited ways of figuring out where to put investment dollars. And the only real answer is, what's the return on this investment as opposed to this one? And you're making an argument for an electronic health record because you think it's cool or because you think it's the right thing. Well, I get all that, but I also think that putting up nice buildings is cool and buying Da Vinci robots is a good thing. And I have to figure out which places to place the money. So learning that language. I think that the role, as I understood it and as I grew into it, of the clinical leader is to understand all of the worlds you have to navigate in. The physician world, the world of the larger clinical enterprise, the financial world of healthcare, the political world of healthcare, and to make all of that kind of work together, to understand it, to give people a common vision, and to help them march into the future. It may sound like it was easy. It wasn't. I had websites devoted to my demise, literally. I had doctors get kind of physical with me, but the good thing is, in case you didn't see me, that didn't work out for a lot of them. So it helps to be intimidating physically, maybe. I don't know, I should stop there. But, you know, I think you could say that our bios are not what you would have expected, are they? For any of us. And yet here we all are. And so think about what it means to be a leader as opposed to what it means to be a manager.
That's very good, very insightful. I'll tell a little bit about my journey. I remember the day, actually, I began my journey. I was a deputy chief of staff at our hospital, so medical governance and that, I was kind of into that at the time, policy, procedures, how do you govern a bunch of people that don't want to be governed. I got a kick out of that for about 6 or 7 years, and it was, we were building a new hospital, and the chief of staff comes to me and says, Asim, you know, we need someone to help us pick these new systems and software and implement them. And, you know, there's nobody that wants to do that. So I was like 2006 or 2007. So it was like a quiet little conversation about, would you mind? There's a couple of committee meetings. I don't think it should take that long. They're going to pick a system, and then I think they just have to install it, and then that's it, I think.
I say that all the time.
Yeah, so, you know, you're not going to get paid anymore, and, you know, your clinical work will stay about the same, and then you still have to do all the same stuff that you did before. I said, okay. You know, so at the time, had no idea where I was going and what the journey was all about. And same as the panelist, I know nothing about IT. My kids could, you know, out-IT me any day of the week. But I think what I did understand is around the workflow and kind of worked in the workflow. I think it helped to be an emerge doc. I'm going to put a plug in for emerge doc. We're the canaries in the coal mine, right? We get you know, any problem in the hospital system funnels down to the emerge, and we feel the burden of it all. And we interact with everybody in the hospital. So we have to call our colleagues and get help, and we're interconnected to all parts of the organization. So I think I would put a plug in for emerge docs as being good clinical informatics people as well. And so, anyway, so that journey began there, and then it just progressed on, and I went to a HIMSS conference, I think, a few years later, and I came back and said, Ian, there's this cool title called CMIO that I heard about. You know, it's got a kind of neat ring to it, you know, so anyway, so then CMIO became a thing, and I think, you know, in Canada, certainly, and I don't know what the NHS is like, but certainly in Canada, where maybe 5 or 6 years behind the U.S., maybe 10 years in some ways, and the U.S. was far ahead in embracing a role of a clinical lead within IT. So I think going to those meetings and conferences led a lot to Canada's development. And I think through Peter's work, I don't know if Peter's still in the building, but organizing clinical leaders in Ontario and other jurisdictions is a great opportunity to learn and grow and enhance and elevate the role. And you know, many hospitals or organizational clusters may not recognize that role, but it's a key role in delivering I guess adoption and success for programs. And my mentor, you know, whenever I was implementing or looking at a system, I would always test it on myself. You know, if it doesn't annoy me at 2 in the morning, then I'm okay, you know, launching it. That it doesn't slow me down and bother me, then I think I can talk openly to my colleagues about it. So that was another important feature of, I think, success and what I learned early on in my career. So anyway, I'll stop there. I've got some canned questions, so we can go to that, or if people want to start with questions in the audience, we can go with that too. We've just got so much experience and wealth of talent on the podium right now. So we've got anywhere from Singapore to the US to the UK here. So if people aren't jumping, then I'll ask questions, but okay, so I'll jump in. So I guess really around you know, key attributes and unique features and qualities that we think would be successful, that you found successful in your own career. So maybe I'll start with Andy with that one.
Patience and persistence. Remember, I said I thought it was a good idea to do this in 1987. succeeded in my own operating region about 10 years later, and succeeded across all of Kaiser Permanente 20 years after that. So I think it's very difficult. The second thing is to recognize that what you're really doing has almost nothing to do with technology at all. Yes, the technology seems to be the center of it, but it's actually the largest change management project at any health institution that you could imagine. The metaphor that another physician colleague used often was that we were replacing the central nervous system. And so think of it as how to help thousands of people. In the case of the NHS, it's the largest employer in England or in the United Kingdom. Tens of thousands of people literally have to change everything about how they do their work. Everything. Some of it will feel like it's much worse than it was before. And some will feel like it's better, but they don't remember any of that stuff. They just remember the much worse stuff. And so you're asking them to change when they entered a profession that they thought they understood, and now it's going to be very different. So your job as a leader is to understand the technology, but to lead through change, to help people keep their focus on the goal and to help them change and to get through to the other side where they can regain mastery over their careers, their jobs, and their lives. We did a lot of profiling of people, physicians and otherwise, when we were doing this at Kaiser Permanente, because we viewed it as a change management process. And by the way, 50% of the budget was devoted to change management. Sarah's heard me say this, half of the budget. So the national project was a $4.2 billion project. Just so for those of you who don't know the size and scope, today Kaiser Permanente has about 12 million members, and there are close to 19,000 physicians and about 185,000 other people. So think of half of $4.2 billion being spent on helping them change rather than on licensing technology or putting in hardware and software. That is, and so you have to manage that. You have to manage through that and keep them focused on why are they changing. The ones that everybody thought the old doctors and the older nurses and the older people would have the toughest time because they're old. I resent that because I'm officially a senior citizen. That wasn't the case. And probably I see some heads nodding. That may be resonating with you. In fact, the youngest of our clinicians and people were fine because they were, pretty tuned into technology. And the oldest were also fine because they were looking for something to kind of spice up their lives. No, I'm serious. A new challenge. You get in a rut and you kind of do your thing, and you've done it for 20-some years, and it's kind of fun in a way to try to tackle something new for many of them. The people who have the most trouble are the mid-career people. All of you, actually. Because they are at the top of their game. You have an ER doc like Asim who knows exactly how to function in the emergency department. He knows what to do when somebody with chest pain comes, barging through the front door, or a multiple trauma comes barging. He knows what to do. And then one day you're going to say, actually, all that you know is wrong. You got to do it differently now. And they don't like that because it's exactly what he said. It's going to slow me down. It's going to make me inefficient. I won't be as good. And underneath all of that, I will look incompetent to everybody around me and to all those patients. Nobody wants to feel that way, especially really talented professionals. So just understanding that, helping them pass that is the real job. It's not a technical job. So the people who tend to gravitate toward these positions are techies, the ones who like the technology and are good at it, write code and stuff like that. They may also be good people to lead through change, but they may not be. And trying to understand the distinction between the two, because you need the techies too, very, very much so. But the people who can help other people change are the ones who are going to make these projects succeed. And I know someone said, don't do big projects. They're all big projects. Yeah. Making somebody change everything about how they do their work is a big project.
I think the mid-career people have mortgages to pay too, and that's why
Yeah, there are lots of reasons for staying the same.
they don't want to slow down. Anyway, Fiona, do you have any insights?
Yeah, okay, so I think Andy's taken the words right out of my mouth. And my huge, big lesson learned is business change, business change, business change. I don't think you can overemphasize that enough. It's really very uncomfortable for clinicians to do anything differently. So for us in EPS, in the Electronic Prescription Service, although we have computer-generated prescriptions, so they're all computer-generated, but they come out on paper in the early days. They don't now, they all go electronically. But they used to. So they're all computer-generated, but they still had to hand sign, put one signature on each prescription. And I think it's absolutely fundamental. It's the key driver is actually you have to take the pen out of the clinician's hand. And I don't think you can underestimate that challenge enough. So we have 8,500 GP practices in England, and I would say at least one or two GPs from every practice in that country said, well, when am I going to do my coffee? When am I going to? Well, why don't you just have your coffee instead of doing your prescriptions at the same time as having your coffee? So it's those really fundamental changes, and it's sort of getting that business change over to them. And I think you touched on it, Andy, about sort of mapping out what people actually do now and where those touch points are going to be and what's going to be uncomfortable for them. And I think the other thing I don't know whether anybody's looked at the Rob Goffey work, Leading Clever People. Anyway, it's worth a read if you haven't. So I think you have to acknowledge that. So in my, I'm from a nursing background, so I certainly have to acknowledge the fact that medics are all very clever people. I like to hope nurses are as well, but you have to acknowledge that, and clever people don't like to be led. So you have to bring them along. You have to bring them along and feel that they need to feel involved. And so that you're not actually doing something to them or forcing them to do something. They need to have that, you have to have that collaborative approach and cooperation.
Thank you. Peter, do you want to jump in with a question? Go, man. No, you're standing there. I see you standing there. No, go.
Go ahead, Peter.
Well, great panel, and thanks for the opportunity. So I'll ask maybe two brief questions of the panel, and you can flip the order. So one is the statement, and I think you all sort of alluded to that, and that is, there are an infinite variety of healthcare career paths are probably less frustrating than the one that you've chosen and you're discussing this afternoon. So the question is, what is the most important thing that you need to be able to be successful in the roles that you're playing? That's number one. And number two, why do you stick with it? Why haven't you gone off to something else? Because you heard Sarah's story, you heard, I think all of us were sort of taken in on the 5-month, then it became a 5-year plan, and the next thing you know, most of your career is dedicated to it. So what is it that stops you from jumping off and doing something else? Thanks.
Maybe we start
Great
with Sarah.
question.
Yeah.
The question back to you, Peter, is why you're not up here. But that's a whole other
There's a seat
question.
that's empty here. Pete, there's a seat here. Buddy.
I think, I think one of the key things for me is absolutely resilience. I think, as you say, this is not easy work. And then we talk about changing the way people are doing their business. Well, at the same time, the technology is moving at the speed of light as well. So every time you think you have a strategy and you think you have an approach, about 10 minutes later, you got to be pretty prepared to redirect and be ahead of the curve where you can, but also being able to embrace the masses that you're trying to take on the journey with you. I don't think I chose the career. I think somehow it chose me. And I think that I don't think we're all born leaders either. I think we learn a lot of things along the way. I said I feel very humbled by the people in this room that have taught me so much and have improved my ability to lead, and you're one of them. And I think that the things you can't learn are things like your integrity and your authenticity and your honesty and your listening ability. And those are traits I think that we all need. But for me, it's been resilience and a little bit of risk tolerance, because you're going to make some mistakes. You're going to make some big mistakes occasionally. And you have to face those, and you have to learn from them and take them in stride and move on to the next challenge, the next adventure. So those would be my comments, Pete.
Very, very similar to me. I find the whole sort of digital health is so exciting. So, and I think a lot of it for me is about terminology. So I always, as a clinician, I always say to people, we're not putting in IT systems, we're putting in clinical systems. And I think that terminology thing is very, you have to get that message across. So I work with lots of project managers and techies and, you know, technical architects. And I always feel that I'm the bridge between actually what's really out there and what they're sitting in their ivory tower trying to deliver. So I think my other key thing is it's always, everything's always changing, and I love a bit of horizon scanning. We will never know what's coming up in 20 years' time. You know, we've got all this artificial intelligence and all sorts of stuff. So it's an ever-changing world. It's a really exciting world. It's the best job I've ever done.
Yeah, I'd add to what Sarah and Fiona have said, passion. I, at the very start, had what seemed to me a very clear idea of what was necessary to make healthcare great. Great for patients, to put them in even, and I'll say this because it sounds self-aggrandizing, I believed 30 years ago that patients should be in control of their information and their healthcare, and I wanted to figure out how to do that. And at the same time, I believed that doctors and nurses would thrive if they were part of a learning organization, if they were constantly given the information they needed to do care better. Because while they're clever, they always want to be the best. And so learning what they were doing, learning their level of performance, and learning how to make care better was important. So I had that as a core vision, and I just never gave up on it, and I still haven't. And it's interesting to me that that clarity of vision actually turns out to be one of the most important problems. If I look at failed projects, it's because there isn't a single core idea that drives everybody past all of the difficulties, because they are legion. The mistakes are legion. Well, all of us have made them. But going past them is because you know where you're going and it's still the right place to go, and you just have to get there, and that's the passion part.
The only thing I would add for me is that the coolness is the strategy and the planning. That's the part that kind of is neat for me. I like and you got to be kind of strategic in what I call in your vision and the concept, but then you have to be very tactical in your deployment. Because you can't, you got to build a wide system, but then deploy very tactically. So I like the whiteboarding and planning and that kind of stuff. So that part I really liked. And I think patience is the other thing we talked about. I mean, you know, you have to, in my place, I had to sort of kind of handhold MAC and clinical chiefs to say, this is a neat thing, this is a cool journey, and you have to tell them like multiple times until it seems like their idea almost sometimes with some of these journeys. So I think that is another issue. The other big, and I want to ask the panel later, but there's a bunch of questions really around, you know, the priorities that health systems give to IT. And the little line that's set out for IT in various systems, whether it's capital or operational. You know, how do we as clinicians kind of help, you know, move that line? Because I think we all share that same challenge that it's a kind of an afterthought, and you got clinical systems and new technology and the robots and whatnot, and where does IT fit in there when it's the base of everything?
Well, thanks for the wonderful panel and the inspiring answers too, so thank you.
Go ahead, Jill.
Hey. I'm trying to think of how tactfully I can word my question, and I'm not sure that I'm able to. But you know me, so it's okay.
Go ahead.
Fireside chat.
You know, there's lots of folks in this room I think can very much appreciate. I'm not sure how all of us sort of got into this area, but I think, you know, Fiona, a couple of you said we're all here for a reason, and we probably won't give up because we feel passionately about it. But it's not easy, and it's frustrating most days. But one of the things when we're asked about the challenges, often one of the first challenge, or certainly in the top 3 list, is clinician adoption. And so you know, all afternoon we've heard about it has to match my workflow. Only clinicians can talk to clinicians. We have to make sure we have to, you know, treat our MAC with kid gloves and things like that. So I'm wondering how this panel would react to the question about the system is too provider-centric, get over yourselves and just move on. And how do you deal with that? Because you're in that position, right?
I want to jump on. I mean, I'm sure that, but
I'm not
this
sure how
is,
tactful
it's really
that is.
important.
Ed, do you know what I mean?
So it's about what I said a little earlier. We had an important exercise at Kaiser Permanente, and those of you who have read the book about the implementation may remember the picture of the vision. The vision had nothing to do with providers and nurses in the system directly. It had everything to do with putting patients in control of their health and their healthcare delivery. Everything. And so to get over yourselves, if you agree to that vision and the things that were surrounding it that had to do with how you would make the system behave so that it would do that for patients, if you buy that, then every time the argument starts to devolve into this won't work for me, you can remind people, well, it's not actually how it will work for you. It's how will it work for the people that we are taking care of. Or how will it work to help them take care of themselves, which is actually the more important question. So my advice is to gain absolute clarity and agreement about that. And there are ways to do that as a set of change management strategies so that you can gain broad recognition of what the vision is and people buy into the vision first before you decide what software we're going to use, what apps are good, what's not good, is it the cloud or is it all, any of those technical questions are all subservient to, are we going someplace? Do we all understand it? Do we all agree? And when we get into the tough times, will we still be able to say, yeah, we got to do it this way because it serves that vision? I'm sorry, that's what I'm passionate about. So that's why I got into the...
And I really appreciate that. And I'm just wondering, I was in a focus group with some physicians. Some had EMR, some didn't. And one of the clinicians turned to the other one and said, can you believe that a patient this morning had the audacity to ask me what I was typing about them? And they're trying to look at my screen. And so my question, so how many docs do you think share your vision and that we're doing it for the patient?
They ultimately all can. Do you see this? Yeah. I can look at my record here. I'm a Kaiser Permanente member. I can read every damn thing that a doctor has written about me. So they better get used to it. They better get used to it because the record doesn't belong to them. It belongs to the patients, to the people, because we heard that before. And they do. And I don't want you to think for a minute that those 18,000 doctors are in a command and control environment. And I gave an order and they all said, yes, sir. Not, they were the clever people who wouldn't be led. So you have to create a vision that they can grab onto and understand. Most of them are fine and can march forward and keep remembering it. The ones that have a tougher time have a choice. They can, either come around and get on board or, find another occupation because the train has left the station in the US and it will leave here if it hasn't already in Canada. The profession is changing and I think in a healthy way. It's not their data. It's the members, the people's data.
I'd just add, I think we need to deliver value too,
Yeah.
right? I totally agree with everything Andy says, and I totally agree that the world is changing in the right way, and it'll take a while for everybody to get on the boat, but I think they're getting there. But we do have to deliver value for the physicians and as well, and so we have to be very sensible about what we're trying to do. But we'd be amiss if we didn't sit here and reach out to our technology partners and say, yeah, we could be doing a better job with some of these solutions as well, that it could actually be doing both. It could be something that's really providing value for clinicians and ease of use and providing the access and the capability for patients. So I think we've got a ways to go in terms of technical design as well and usability.
I would just like to echo that really. So I've just been scribbling a few notes before, and I think from so we deal with, specifically in our EPS journey, we deal with 12 suppliers, so 8 pharmacy suppliers and 4 prescribing system suppliers, so we do deal with suppliers. And I think from a lessons learned point of view, if I had my time over again, so there's been a lot of talk about standards, and we have the same discussions in England and the UK. Everybody wants standards. But I think one of the standards that we possibly missed out on was the usability and the user interface. So do you call it a gear shift stick here in Canada? You on your gear?
Stick,
yes, yeah. So for me, the brake should be in the same place on every system. The shift stick gear stick should be in the same place on every system, as is the driving wheel is in the same place on every system. They don't have to look the same. You can have added functionality,
If it's
but
on the
some
right
of the
side instead of the left side?
absolutely.
You're sure?
So, yeah. So that when you when your clinicians are actually moving between systems, and they do, all the time, at least they know where to find things. So if I had my time over, that would be my one tip: get usability standardized.
Hi, I have a question for you. So I'm very appreciative of the concept of management in the context of doing peer-to-peer. I think is an incredibly effective way to do this. But I'm challenged in the sense that I don't know how that scales. I'm curious about how do we ensure that proven, effective, digitally enabled practices are translated into the teaching faculties, because you have a whole cadres of people coming up through the ranks. And the sense I get right now of transformation with digital health is that it's being done operationally in place, in real time. And I don't know, are we making that transition to finding a channel to take harvest those practices, formalize them, and then get them into the teaching faculties?
Oh, that's a good question, yeah.
It's a great question, Ron. It's going to be your challenge, I think. Right? Used to be my
Partially.
challenge.
I think that I can't speak for Canada. It's not happening in the U.S. very well. And so much so that several places, Kaiser Permanente among them, have decided to found their own medical schools so that they can raise a generation of clinicians, physicians, nurses, and allied health professionals who learn how to use these systems to the advantage of members and to take good care of populations as well as the patient in front of them. I think it's a crucial next step, and something that the deans of the medical schools are probably aware of, but not figuring out how to take on.
I would just encourage both the clinical leaders, but also the community of vendors that provide solutions, that there has to be a channel created so that when effectiveness is proven and when acceptance is achieved, that can then be in some kind of structured way transferred into the teaching faculties. Because I've had conversations with them, and they're aware that this probably needs to occur, but they don't know how to acquire this knowledge, and they don't know how to incorporate it into their faculty. And their curriculum.
I think you're right, Ron, and I think that we've all become informaticians, even accidentally or just because of the career paths that we're on in terms of healthcare. And so building that capability from the beginning, I think, is really important. It's not just entering the data, it's about how we're going to access that data, analyze that data, and become more of an analytic approach to things as well. I think we're lucky that the next generation is already going to be much more advanced in terms of adopting systems. I think something we've not done well is, as we do go through training, even in situ, as you say, I'm not going to talk about college and everything else, but we haven't gone back to actually improve practice. We get through that one training session and we'd say, thank goodness we got through all 800 doctors that we had to do just in time to go live. But we haven't gone back and optimized and personalized so that they can actually have a better experience. And we're trying to embed that in our projects now. I think we all know that we should do that, but we do get to that point where we flip the switch and somehow that 6 months of optimization is kind of like it kind of just doesn't quite go the way you think it's going to go, and we don't go back and revisit. And then we've got frustrated physicians and the huge number of emails now about productivity and so on. So I think there's two things. Getting more advanced early on is fantastic, but we can't forget to close the loop on the other end and constantly improving the capability for the physicians in their workplace.
And I find the younger group are pulling us along in a lot of ways. They come in and they say, and I like them when they're brand new to the organization, because they say, isn't there a faster way to do this or a better way to do this? And they ask good questions. I think the challenge is scaling along people that are difficult to adopt. So, the challenge is, and Sheila's question around, no one's dying in the hallway because of this problem, right? I mean, I'm a good clinician and provide good care. I've been doing this same process for 20 years or 30 years. And then how do you disrupt that change? And Michael talked about it earlier, is around the disruptive nature of what we're trying to do. And it's up to us also to come up with the benefits piece. What's in it for them, what's in it for the patients, and bring it back to that, and bring it back to quality and safety where those indicators are important, or patient preference and patient experience. And I think that's the principles that we need to hold to, but you need to have everyone agreeing. And I don't even take on a project unless everyone around the table at MAC is nodding their head, that I have the agreement and support of all the chiefs. Because if something is going sideways or becomes difficult, I need everyone's support to kind of pull through that project. So that high-level agreement and alliance is going to be critically important for adoption and scaling. Sorry, we have another question?
Thanks. When I started implementing EMRs, I was told that always to remember that once you've convinced one clinician that it's working and you have them bought in, then you've got one clinician on your side. In your initiatives, which have hit large numbers of clinicians, has there been a point, or is there some activity, some mechanism that you believe got you from the stage where it was the one-by-one selling per clinician to a point where there was a more general acceptance and people were wanting to adopt on the clinical side?
Shall I?
Sure.
Yeah.
You go first.
Yes. So from our point of view, it was frustratingly slow in the beginning. So about 2009, 2010, we were waiting for our suppliers to come through. We had to have all our dispensing suppliers enabled before we could enable any prescribing supplies. And I think the clinical community just thought, this is never coming, so, you know. But then it did come, and it was quite slow. The systems were a little bit clunky, if I'm honest, in the beginning. The user interface wasn't great. It was just generally clunky. And so adoption was steady, but frustratingly slow because we didn't have all the system suppliers in place or the prescribing supplies in place. And, we just thought, I can remember the day we said, yay, we've sent 1 million prescriptions, and that seemed to be going for a couple of years. Actually, we create 1.7 million prescriptions every day in England. So, it sounded like a big number, but actually it was a tiny, tiny proportion. And then suddenly, I think as we started to work really closely with the system suppliers and say, usability, 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 you have to do something about this, it's clunky, it's not working for the clinician, they started to listen, and then suddenly adoption just ramped up. And so now we've got, all other different care settings are banging on our door for the solution now that, we're struggling to keep up with demand.
I think there's stories too. I think that, within your who called them the tribe? Is that you, Kathy, the tribe? The tribe. Within the tribe, there will be stories about, I just used that X, Y, or Z, and you know what happened? And capturing those stories and propagating those stories, I think, is really important. It becomes much more personal. And I never, ever underestimate the competitive nature of physicians wanting to do better than the guy next door. So I think there does come a certain momentum where, well, if everybody else down the hall is doing it, I better get on it. In fact, I better do it better than them. And so
I would say that the tipping point comes when everybody suddenly realizes that they don't have to function in the absence of information about their patients. And it can happen sooner than you might expect. When we were about 6 weeks into the deployment in the Kaiser Permanente Mid-Atlantic region, which is Washington, D.C., Northern Virginia, about 500,000 members and about 1,000 physicians. We were 6 weeks in. A lot of doctors in the ambulatory setting were already live. And there was a catastrophic power failure at the data center that served them. Literally melted 1,000 servers. And I won't get into how that happened, but it did. And so we had two alternatives that we were considering in terms of bringing it all back up online. One was we would just shut everything down, put them back on paper, because it had only been 6 weeks that they were up, and then fix it really quickly all at once. And the other was we would baling wire and glue and chewing gum and so on, get it back up so they could function during the day, because it was mostly an ambulatory setting at that point, bring it down every night and do bit by bit, do repairs. And we posed that to the doctors. And so we could shut it off and go back to paper, and we'll bring it back in a month. Or we can do this other way. And And the reaction stunned me, because I assumed they would say, shut it off, you know. And they all said, are you nuts? You know, fix it, and fix it now. Don't you hate it? Yeah, we hate it. Fix it. So we knew that it was the information in there that they suddenly realized was so vital to high quality care that they refused to do without it in the face of all sorts of obstacles. And once you get to that point, I think you will have, they won't stop complaining. They won't make you feel like they want you to turn it off, but they don't want you to turn it off. They want you to fix it. And the UI is the key piece.
That's a great response. I think the other thing I would add is that I think, and to Dave's point earlier, the too early and too late, the two ways of advising. Sometimes we come out with a completely finished product, and that's all it is. And I think one of the other things we need to do is with the vendor community as well is that promise to continually improve the deployment, because it'll never be perfect right out of the box, and we have to appreciate that. And so we pay lip service to saying, oh yeah, let's come in and let's test it out, and we'll take back your feedback. Clinicians are really annoyed if they come and give feedback and test things out and it goes nowhere, right? It really annoys people. So I think there has to be a commitment, especially on large-scale projects, that it'll be continued to renew, and we have this quick cycle of turnaround and new deployments and new additions, and the funding and the budget and the RFPs and the contract should all kind of reflect that, because it is not a static process of developing and then deploying something. So I think that'd be key as well. Thank you for your question.
Thanks very much for your perspectives. I'm Laurie Poole from the Ontario Telemedicine Network, and one of the wonderful benefits of digital health is that we can deliver care closer to home, including in the patient's home. And on the flip side of that, one of the most dangerous handoffs in healthcare is from the hospital to the home. And so there's no doubt that the home and community care is going to continue to grow because people want care delivered closer to home, and digital health is allowing that. So I'd just be very curious about your perspectives of how we build and bridge that connection between hospitals and the home and the community, and kind of leveraging your learnings and your insights on that.
Sarah, you want to kick that off?
Well, I think we've addressed it in a couple of ways, Laurie, but I agree absolutely with what you're saying. I think, firstly, the patient empowerment and giving them access to their information, be it through portals and other mechanisms. The information goes with them regardless of whether they're in hospital or transitioning out. I think that's at the core of it. But I think I think the use of the remote technologies and the ability for patients to, I guess there's one thing, I always think about how we make it more bidirectional as well once they're in the home, and having that access to the expertise, to their clinician, and making that more enabled. I think, we've traditionally done, I think, and you guys are so fantastic at this, creating this environment for successful telehealth, but what we're finding is we've got all this other telehealth that's going on where patients are reaching out to their colleagues. And we've got doctors reaching out to doctors. And so we've got this other sort of undercurrent of communication. At the core of it is all about communication. So I think we need to think long and hard more about some of the technologies that we've traditionally associated with this, how we start using our mobility and other things in a more effective way. So, and it's more spontaneous and less of the scheduled and regular type of virtual visits that we've been doing historically.
So I would say, first of all, thank you. You highlighted 2 out of the 4 pillars of Kaiser Permanente's vision as it was elaborated in 2002. One being home as the hub, and the other being secure and seamless transitions. And so the idea behind that is you design the system to make those things happen. We recognize, but not even as much as the Kaiser members did, that a lot of the transactions, the need for patients for support or families for support and information could be handled asynchronously. And so I'll give you a fact that has emerged over time. First of all, the portal, the member portal, that Kaiser Permanente members use is actually it's simply a view into the record, which is a single record that has all kinds of things in it. It's not a freestanding, separate thing. So, and it's one way that they have of communicating with their clinicians. When it started, of course, the only ways that people had were visits. They could come actually see somebody in one way, including that or a telephone call. There were occasional letters, but those were the two things. Kaiser Permanente counted those things. They called them touches. Today, 50% of all touches are through asynchronous secure messages through the portal. Half. Visits have fallen by, compared to 2001, 2002 norms, by about 25 to 30%. Emergency department visits have fallen by a similar amount, and hospitalizations, interestingly, have also fallen as a rate. So people can get what they need in this new way, and they're used to doing it now in all sorts of venues, and so it's sort of astonishing that we don't do it in healthcare. The fact that it's all stored in one place means that any healthcare worker who is dealing with that person has no excuse for not accessing the information when they're taking some step or some decision related to that person. And the people know, too. So if you go to a long-term acute care facility, there is no reason, and there is every reason to understand exactly what happened in an acute care setting. When you go from the LTAC to home, everybody in your family has access, if you wish to give it to them, to all the decisions that were made and the medicines you're supposed to be on and the ones you're not supposed to be on and so on. So I think that making a unified single record for a person is a crucial part of avoiding a lot of the transition errors that happen. Because if you have a record at the hospital and another record at the LTAC and a third portal where you may store some of your own information that you keep track of, like diabetes care folks often do, that is a recipe for insecure transitions if you're not extraordinarily careful. So single record and a recognition, and I've probably done this with the Canadian audience. There are doctors here in the room, any physicians who do primary care? Nobody? Oh, there's one. So, sir, if you have a really sick patient, stand up. I want to hear from you. If you have a really sick patient, really sick heart. We talked about heart failure earlier. Somebody with heart failure is really ill. How often would you say they come to see you? Every 3 months. Okay. In the U.S., doctors in fee-for-service would say once a week, right? And the visits are about 15 minutes, so if you do the math, it's about 780 minutes a year that they're actually seeing somebody that they think is very sick. So it's actually delusional to think that you're taking care of that patient, even with that frequency of visits. They are taking care of themselves, and the job is to figure out how to help them do that, to give them all the information they could possibly use and to make decisions and to know when to contact you and when to escalate and seek higher levels of care. So when you design the system to support that, it's a very different looking system than something that's designed primarily to make sure documentation is easy for doctors and nurses, which it needs to be as well.
Great. The only other thing I would add is there's some innovative programs in Ontario around connected care, especially around discharge to the community. So we've got a program called H2H. So really the nursing staff goes with the patient and carries on through the home care environment. So if we kind of break down some of the silos that we have in healthcare in terms of where people work and how they function between systems, that would be kind of neat as well. Clinicians working across seams, like our palliative care positions are now LIN-based resource so that they're freed from the hospital setting in terms of that's the only place they can provide care. So I think that'd be kind of a neat thing is have maybe people in the care team perhaps think about following the patient. So we'll see what the results of some of the work in Ontario is. Anyway, listen, we're right out of time. It's actually 000 here. And that's probably bad. Anyway, I want to thank the panel here. I think we had a great session. I didn't know where things were going to go, but I knew we had the right folks in the audience and on the panel to help us. So I want to thank everyone for coming and thank everyone for participating. Thank you very much.